Okay, good morning, everyone. So I always feel like this room is so large and everyone's so far away compared to the other ones. So please feel free to stop me as we're going along. I think in the last two sessions, we only got through like 2 cases each because there were lots of questions, but I want this to be most helpful for you. So yeah, just raise your hand or shout something out as we're going. I will repeat it. That will be the first thing I will do, don't worry. Okay. Okay, so we're just going to jump into the first case. This is a 31-year-old lady that comes into the office with diplopia and headache. So to give you a little bit of background, her symptoms started about 2 months ago. Her headaches were initially intermittent, but they've become constant within the last 2 weeks. A few days prior to her symptoms starting, she had ridden a roller coaster. For any roller coaster fans, this is Top Thrill Dragster at Cedar Point. That's in Sandusky, Ohio. That's unfortunately closed now. And then 1 month prior, she had started a vigorous aerobic exercise program. She did see an optometrist because of this double vision she was experiencing, who noted a right abducens palsy, and they had ordered a CT scan of her orbits that was normal. So that's some background on this first case. So not just this first case, but in general, when you're seeing a patient with headache, what are some characteristics or what are some headache history points that you want to be asking them about? And you guys can shout some out here. Or what are some additional details you want to know about her headaches? Character of the headache. Correct. What is the headache like? How do they describe the headache? What else? Frequency, severity, duration of the headache. What else? Alleviating factors, exacerbating factors, and I think I heard somebody say associated symptoms as well. So that's right. So anybody, the first time, our first step is to clarify their headache presentation, right? So a detailed and careful headache history is really important. Because primary headache disorders are clinical diagnoses. There's not a blood test, there's not an imaging test. Their description of their headache is what's going to clue you into the diagnosis. So things like character, severity, duration, associated symptoms. Are there migraine symptoms? Are there autonomic symptoms? Are there focal neurologic symptoms associated with their pain? And are there any exacerbating or relieving factors? It's helpful to also know, has there been a change in their headache pattern? Do they have a history of a headache disorder and they're having new types of headaches? What has the progression of their headaches been? So you get some additional detail from this lady. She tells you she has a few different types of pain. She tells you she has right temple pain with some burning into the right cheek and the right ear, as well as some sharp retroorbital pain. She also has dull pain in the neck that radiates to the occipital region and then gets these sharp jabs of pain just right to the vertex. She has severe phonophobia, some mild photophobia. She has nausea, confusion at times, and tinnitus and dry heaving. Her headache is present upon awakening. She had told us that for the last 2 weeks, they've been constant. So it's there when she wakes up, but it's generally mild, and it worsens as the day goes on, up to an 8 out of 10 in severity. Things like coughing, sneezing, bearing down can increase that pressure sensation that she has in her neck. Lying flat improves the headache, and standing worsens it. Caffeine also helps her headache, so she's been drinking more coffee. So that's her headache HPI. I'm going to give you guys some additional information in her physical examination as well. So you do note the right abducens palsy that was seen by her optometrist. She has impaired right eye abduction. That's about 50% of normal. Her fundoscopic exam is normal, and spontaneous venous pulsations are present. She has some joint hypermobility in her fingers and her wrists and her hips. Cardiac auscultation is normal. And then you decide to put her in Trendelenburg, and you note that her headache resolves and her right abducens palsy improves after she's been in Trendelenburg position for 10 minutes. So what are you thinking about here? I heard it. Who said it? A dural leak, a spinal leak. So this is a pretty nice history for a low pressure CSF leak headache. What would be your next step? So she had a CT orbit. So it sounds like spinal imaging. Do you want to do any other type of imaging? Probably an MRI. Yeah, so an MRI brain. So this is actually one of my real patients. We did end up getting an MRI brain scan with and without contrast. And her MRI brain, as you can see, was normal. And I was like, what is up with this? Because what a classic story, right? For a CSF leak and intracranial hypotension, and she had imaging that was normal. And the reason I like to put this patient up here is just to highlight how much variability there can be in spontaneous intracranial hypotension. And this is, I think as a headache specialist, this is like my least favorite headache disorder because it can be so hard. It's a clinical enigma, right? It can be so hard to diagnose. The presentation can vary so much. Imaging is not always abnormal, and they don't always respond to treatments. So it can be really challenging clinically. So specifically in this patient, we don't see any brain sag. There's no pituitary enlargement. There's no chiasmal flattening. She does not have any meningeal enhancement. However, because of her history, despite the normal imaging, there was a high clinical suspicion for spontaneous intracranial hypotension. So she did undergo 2 sequential high-volume lumbar epidural blood patches. After the first one, she actually didn't have much improvement, but then after the second one, she improved about 75%. She had some brief rebound intracranial hypertension that was treated with a short course of acetazolamide. Because of her joint hypermobility, she saw genetics. She had genetic testing for Ehlers-Danlos syndrome that was negative, and her symptoms ultimately resolved. She actually did not follow up with me after, so I'm assuming things were perfectly okay. But that was the conclusion for this case, and I just want to talk a little bit about spontaneous intracranial hypotension. This is the diagnostic criteria from the American Society of Neuroradiology. And we'll go through this a little bit, but there's a few different ways that you can make this diagnosis. And you don't necessarily need abnormal imaging to make it. So one, if you look at A, demonstration of a spinal CSF leak. So spinal imaging that shows a spinal CSF leak in the setting of having a typical orthostatic headache, you're done. You've made the diagnosis of spontaneous intracranial hypotension. If spinal imaging is normal, you can still make the diagnosis if they have cranial MRI changes of intracranial hypotension and the presence of at least one of the following. So low opening pressure on lumbar puncture, spinal meningeal diverticulum, or improvement of symptoms after epidural blood patching. And if your spine imaging and your brain imaging are normal, you can still make this diagnosis if the patient has a typical orthostatic headache and 2 of the following, so low opening pressure, spinal meningeal diverticulum, or improvement of symptoms after epidural blood patching. So this just really goes to show that presentation can be variable, and imaging, because the imaging results can be so variable, a lot of times these patients will have a long delay in diagnosis. So by the time they get to you, or by the time they get to a neurologist, they may have been having these symptoms for a long time, and we can see that sometimes that positional component can become less prevalent the longer they've had these symptoms, so it can be a bit harder for that to be at the top of your list or to be able to tease this out. So that's, again, where that headache history, taking a careful and detailed headache history and pursuing this testing if you have a clinical suspicion is important. So symptom-wise, what do we see in these patients? Headache, so an orthostatic headache that's worse on sitting up or standing up and improved on lying flat. The location and quality of the pain can be pretty variable. In our patient, she actually had this temple pain, but she also had like face pain and ear pain, pain that went into the neck and the back of the head. Neck pain is fairly common, and we see headache because the thought is that there's this downward traction on pain-sensitive upper cervical and cranial structures that ends up being responsible for the headache itself. Headache symptoms are usually exacerbated by activities like coughing, sneezing, laughing, lifting, bending, Valsalva. Sexual activity or exertion can also worsen symptoms. And you can imagine if you have that brain sag and then you do something like you cough or you sneeze, you're kind of almost getting this like transient obstruction of CSF flow. So that's what causes the worsening. So it's kind of like a paradoxical thought process here for why they get worsening with these conditions. And they can have a variety of associated symptoms. So they can have migraine symptoms like photophonophobia and nausea, but they can also have visual symptoms, diplopia and blurred vision. They can have facial pain. They can have imbalance or tinnitus. They can have some cognitive changes, and then they can have radiation of pain into their chest or into their back, depending on the location of the spinal leak. The key thing is that these symptoms are usually alleviated in recumbent position, and as opposed to migraine, where symptoms get better but don't go away. They feel better when they're laying down. A lot of times, these symptoms will go away when these patients lay down. And then things like caffeine or high altitude can also be helpful here. So as far as testing, lumbar puncture is really only helpful if the CSF pressure is low. However, most patients with spontaneous intracranial hypotension will have normal CSF pressure. So if you do a lumbar puncture and the pressure is normal, that doesn't rule it out. I think there's something like 30% of patients with SIH actually have low CSF pressure. The majority of patients have normal CSF pressure. Generally, CSF studies are normal, but they can show a lymphocytic pleocytosis or an elevated CSF protein. MRI brain with and without contrast should be done in all of these patients, and most of the time this will be abnormal. It's abnormal in 75% of patients, and you can see a variety of findings that are suggestive of low intracranial pressure, things like brain sag with cerebellar tonsillar descent, pituitary enlargement, thickening and enhancement of the meninges. You can see subdural fluid collections or subdural hematomas. These patients can get subarachnoid hemorrhage or venous sinus thrombosis. So there's a lot of different things you can see on imaging that can be suggestive of low intracranial pressure. And then a spinal MRI with and without contrast can also show evidence of CSF leak. And here you're looking for things like extrameningeal fluid collections, extradural extravasation of fluid, meningeal diverticula, engorgement of epidural venous plexus. So this is just some examples of imaging. So in panel A here, you can see that this patient does have brain sag, and there's this downward descent of the cerebellar tonsils. She also has some flattening of the anterior pons here, and then there's some downward displacement of the posterior corpus callosum. And then in panel B, you can see this nice uniform thickening and enhancement of the meninges. In patients, generally in patients that have an orthostatic headache, and you get a spinal MRI, and they have evidence of, they have signs consistent with a spinal leak, you can usually move on to a non-targeted autologous blood patch. Sometimes patients will respond, sometimes they won't. If they don't respond and you are still convinced that they have a spinal leak, then there is some utility in finding the leak and doing a targeted blood patch. But the leak can be very elusive. So the leak is really, in half of patients with spinal CSF leaks, the leak is not found. The location of the leak is not necessarily found. There's a few different ways that we do this. You can use radioisotope cysternography. This is where the radiologist will do an intrathecal injection of a radioisotope, and then followed by scanning at predetermined intervals to track the dynamic flow of the isotope. At our institution, we do CT myelography, which is really the gold standard, the best test to identify the exact site of the CSF leak that's caused by a dural defect, and that's because it allows for this real-time visualization of the contrast agent as it's traversing along the spine. There is a lot of technicality associated with CT myelography, and it's only as good as the neuroradiologist that is doing it. So it's really important to have a skilled and experienced neuroradiologist. And this image here actually kind of highlights that. So this is a CT myelogram in a patient in panel A. This is the patient in the prone position being scanned, and we don't see any evidence of contrast extravasation. And then in panel B, though, the patient is turned on their right lateral decubitus side, and you can start to see that there's some contrast extravasation right where that arrow is, indicating a low CSF, a low flow CSF leak. So again, it really highlights this testing can take time, and it also highlights why these leaks can be missed and why so many times the diagnosis can be delayed or leaks are not found because there's a lot of technicality associated with how the testing is done. So how do we treat these patients? Conservative treatments are usually first line, or are first line, but are often unsuccessful. Conservative treatments include bed rest, Trendelenburg position using an abdominal binder, increasing fluid intake. Caffeine or prednisone taper can be helpful symptomatically. GON blocks for neck pain or musculoskeletal pain in the occipital region can be helpful as well symptomatically. A greater occipital nerve block. Occasionally, these leaks will resolve spontaneously, so especially small leaks, but if symptoms are persistent, then a non-targeted autologous high-volume epidural blood patch should be pursued, and if the patient has relief of symptoms, even if it's transient, this can support the diagnosis of spontaneous intracranial hypotension. If there is a structural etiology, if there is a spinal meningeal diverticulum, if there's a dural defect, then surgery to fix that structural etiology should be pursued as well. Keeping in mind that once a leak has been successfully treated, the prognosis is generally good. However, leaks can recur and new leaks may develop. This population of patients, I think, can sometimes be a little bit difficult to manage because sometimes every new symptom that they get, the concern is their concern and your concern can be, do they have a new leak? Do you need to repeat all of this testing and how are you managing it? So it can be a bit tricky clinically. I also think that there is some value in sending patients to like a specialized CSF leak disorder center if you continue to have a high clinical suspicion for a CSF leak disorder, but they're not responding to the treatments you have available, your imaging is not showing something, and that's really where you kind of look at more kind of dynamic spinal imaging to find the leak and do targeted treatment if possible. Yeah. So there are some risk factors. Sorry. Oh my gosh, I missed it. So the question was, why do people get spontaneous leaks? And so there are some risk factors. So we look at things, there are some rheumatologic conditions that can predispose patients to developing leaks. Connective tissue disorders, particularly Ehlers-Danlos syndrome, can predispose patients, female sex. And then also if a history of trauma as well, so I will often counsel these patients, especially if they have something like joint hypermobility and they've had a leak, is avoiding kind of rapid manipulation of the cervical spine, avoiding activities like roller coasters or weightlifting to help prevent further leaks from occurring. Other questions about spontaneous intracranial hypotension or spinal leak? Yes. So the question was that Rathke's pouch is often commented as a, sorry, I didn't hear it. On MRI, and some people think it can be a precursor. I guess my opinion is it depends on the patient and it depends on the symptoms. I don't think there's a specific intervention to do if it's present, unless there is, particular orthostatic headache that you're trying to treat. Other questions? Okay, so we will move on to the next case. So this is a bit more bread and butter headache clinic type of case. Oh yeah. So the question was, in cases where imaging is normal, how do you make the diagnosis? Is that correct? So I think you really fall back on your headache history. So if you have a high clinical suspicion for a low CSF pressure headache, so you're looking at the characteristics of the headache, and the biggest component is the orthostatic component. So if patients are consistently able to describe an orthostatic component where the pain is worse with sitting up or standing up, and then it improves when they're recumbent, that should always raise a concern. And then in those patients, even if imaging is normal and I have a clinical suspicion high enough, I would still treat as a spinal CSF leak and do a blood patch. Okay. So the second case, this is a 31-year-old female attorney. She complains of a history of sinus headaches that occur about 3 times per month since she was a teen. She tells you she has unilateral retroorbital pressure and throbbing pain. It's moderate to severe in intensity. It's associated with nausea, light and noise sensitivity, nasal stuffiness, and sometimes nasal drainage. It's worse with movement, so she usually has to lay down when she gets them, or she has to call off from work. Triggers include changes in weather and her menstrual cycle. She reports that her mother and her 2 sisters also have similar sinus headaches. She's tried over-the-counter sinus medications. She's seen her PCP several times, has tried several rounds of steroids and antibiotics for sinus infections, but the headaches have continued. Her medical history is otherwise negative except for a history of mitral valve prolapse, anxiety, and panic attacks. And her physical exam, including her neurologic exam, is normal. So a few more details about her headache, since we talked about what details in her headache history we want to be asking for. So she says her headache is typically unilateral, but it's not side-locked, so that means it can switch sides, and it sometimes involves the whole head. It can occur at any time of the day. It can wake her up from sleep. Her pain typically lasts 8 to 10 hours without treatment. And her nasal congestion that she endorses is bilateral. She does not endorse any other autonomic symptoms. And overall, she averages 3 to 4 headache days per month. So what do we think? Does she have sinus headaches? No. What does she have? She has migraine. Yeah, this is migraine. So this is the ICHD criteria for migraine without aura and migraine with aura. So in order to diagnose migraine, patients need at least 5 attacks. The headache needs to last, and it's a longer headache, right? So it lasts anywhere from 4 hours to 72 hours when it's not treated. And characteristics include unilateral location, a pulsating or throbbing quality to the pain, moderate or severe pain intensity, and aggravation by routine physical activity. And then keep in mind, and you can see there, that they only need 2 of those 4 characteristics. They don't need all 4 of those. And then during the headache, they have at least one of the following: nausea or vomiting, or photophobia and phonophobia. And I always find this interesting, because when we talk about, sometimes I'll talk about this with my residents as well, and we talk about the diagnostic criteria, and when you see that you only need 2 of those following characteristics, a lot of times they'll be like, oh my gosh, I've had migraine, so you can realize that many headaches, even though you may not really think, oh, this is a migraine, if you look at the diagnostic criteria, a lot of headaches will actually meet criteria for migraine, so it's a lot more prevalent, a lot more prominent than we may suspect. Table 2 is showing criteria for migraine with aura. Aura is a transient neurologic symptom that consists of visual, sensory, or speech and language symptoms that are fully reversible. So that's key there. They are fully reversible. And they can last anywhere from 5 minutes to 60 minutes. It's usually unilateral, but it generally has some sort of spread, so it'll spread gradually over 5 minutes, and you can have multiple aura symptoms. So you can have a visual symptom and a sensory symptom or a speech symptom kind of along with it. The aura is accompanied or followed within 60 minutes by a headache. The time course is really important here, so lasts at least 5 minutes and not longer than 6 minutes. Less than that or longer than that would be unusual for migraine aura. So just going back to sinus headache. So I'm sure all of us have had patients come and say, hey, I have sinus headaches, right? If you talk to a headache specialist, many of us don't really believe in sinus headaches, although sinus headache is part of the ICHD-3. If you look at the diagnostic criteria, though, in order to diagnose a sinus headache, a patient needs to have clinical or nasal endoscopic or imaging evidence of acute rhinosinusitis. So during the episode, they need to have purulent nasal drainage. If they see ENT and they do an endoscopy, they see gunk in their sinuses, or you do a CT sinus and there's opacification of a sinus. So you need to have true evidence of sinusitis, and there has to be a temporal relationship with the headache. So the headache comes on when the sinus infection comes off, and it gets better when the sinus infection is treated. But it is unusual to have recurrent stereotypical sinus infections, right? Every single month when there's a weather change or menses, or when somebody has their menses. So if somebody is coming into you and describing these recurrent stereotypical headache episodes, migraine should really be at the top of your list. So how do we explain her stuffiness and her drainage? She says she has nasal drainage. She says she feels congested. I don't remember, but she may say she has this like sinus pressure as well. So how do we explain that? 45%, so almost half of all migraineurs will have at least one autonomic symptom during an attack. And these autonomic symptoms can include lacrimation, eye redness or ptosis, eyelid edema, nasal congestion or rhinorrhea. The key here that in migraine is these symptoms are bilateral. And that distinction is important if you're trying to distinguish between something like a trigeminal autonomic cephalgia, where you would have ipsilateral or unilateral and side-locked autonomic symptoms. And this occurs is because during a migraine attack, there's parasympathetic activation of the sphenopalatine ganglion, which innervates the tear ducts and the sinuses, that leads to these drainage and sinus type symptoms. Additionally, people will say, well, oh, I don't have pain in the head. My pain is here in the face, or it's in my forehead. And that's because there's activation of the trigeminal nerve, which also provides sensation to the face. So pain can occur in all distributions of the trigeminal nerve, including the face. So that's how we can kind of explain her stuffiness and drainage. And this is how I like to explain to patients as well when they are, because people will come in and they're very convinced they have sinus infections and they have sinus headaches and they want to take decongestants and they're not getting better. And it's like, well, hey, you're not responding. This could be migraine, and let's treat it as migraine and see how you respond. So before we get into treatment, does she need any testing? I see some head nods. No, she doesn't. So if you remember, she had a normal neurologic exam. She did not endorse any focal neurologic symptoms with her headache. So neuroimaging is not necessary for most patients with migraine. Yeah.
Can I push on one thing?
Yeah.
So she, and again, I wouldn't do it here either, but she did mention she'll wake up in the middle of the night sometimes with the headaches, which would at least pique my interest. Can you comment on that?
Yeah, so nighttime awakening, the question was that in her history, she commented that she wakes up and that the headaches can awaken her at night, which Dr. Stevens said would pique his interest. So nighttime awakening can be a red flag for headache, but I think we like to take the whole picture into account here, right? If this was a brand new headache and that was totally waking her up from night, and it was different in character from her typical headaches, but if this is something that's been going on since her teens, it's usual in character, and she doesn't have any other focal neurologic findings, most likely imaging would not be necessary. And I think I note here, so like the AAN guidelines suggest considering imaging in patients that have an unexplained abnormal finding on their neurologic exam, if they have atypical headache features or headaches that don't fulfill the strict definition of a primary headache disorder, or if they have some additional risk factors. So if she's somebody that had a cancer history and is now telling you she's getting headaches that wake her up at night, that even though they sound like migraine, that may prompt you to get some imaging to rule out a secondary cause. If they have some sort of immune deficiency, if they're immunosuppressed for any reason, then the presence of these additional risk factors would prompt some additional testing. Yes. I think that's a good question. So the question was, we had made this distinction in this case that this patient has unilateral headaches, but they're not side-locked. But if a patient does endorse side-locked headaches, even if they are migrainous in quality and they are not consistent with a trigeminal autonomic cephalgia, do you still get imaging? And I think that's where your kind of clinical suspicion really comes into play, looking at the patient as a whole. Are there other risk factors? Could there be other contributing features to their headaches? So where you're talking about migraine, and I don't talk too much about this, but when I think about migraine and side-locked headache, the other thing that comes into mind is something like occipital neuralgia or cervicogenic headache. Do they have something, another factor that's kind of contributing to that headache only on one side? So I think that's where your kind of clinical suspicion and looking at other factors that are that the patient is coming in with kind of play a role in your decision to get imaging. And then also, if they're not responding to treatment, if you're treating them as typical migraine and they're not really responding, then that makes you wonder, hey, is there something else going on? Or is this a weird hemicrania without autonomic, which is like a whole other story, but is this a weird hemicrania continua without autonomic features or without strong autonomic features? So that would be, I think, a reason if they're not kind of responding. And that's why we're following these patients over time too, right? To see what that response to treatment is. But in general, no other testing is typically necessary in patients that have suspected migraine that fulfill ICHD-3 criteria for migraine. Red flags, so you guys have probably seen SNOOP4 mnemonic before. So red flags to keep in mind if they're presenting with systemic symptoms like fevers or weight loss, if they have focal neurologic symptoms, if they have, if it's an older patient with a new onset headache over the age of 50, if they have thunderclap onset to their headache, if they have papilledema, if there's a positional component, if it's a progressive headache or a pattern change, then these would be red flags that should potentially prompt you to get imaging. And I think, again, it's really important that each patient is so individualized, and as you get to know your patients, you're following your patients, you may pick up, hey, this is unusual for this patient to have. It's always hard on the first visit, but if there's pattern change or progression of their symptoms and they're complaining about something that's not really typical for them, then that should prompt you to get additional workup with neuroimaging. So going into treatment now, so our patient has 3 to 4 headache days per month. So she falls into the low frequency episodic migraine category. So when we look at episodic versus chronic migraine is patients that have at least 15 headache days a month or more, and less than 15 is considered episodic. Low frequency episodic is considered less than 4 or less migraine days per month. So for her, she is low frequency episodic, and she would probably be okay with using just migraine specific rescue therapy. She does not necessarily need to be on preventive therapy unless there's a patient preference or there's some other reason for her to be on it. But she does not necessarily need to be on preventive therapy, and we could get by with just acute treatment. The goal is to use migraine specific therapies as first line agents in these patients. So I have NSAIDs on here because you can still use them even though they're not necessarily migraine specific, but you can use prescription strength NSAIDs like naproxen, ketorolac, or diclofenac. Triptans and ergots and gepants are migraine specific therapies, and then ditans is another group that we'll talk about as well. Triptans and ergots should be avoided in patients that have coronary artery disease, cerebrovascular disease like stroke or TIA, they have peripheral vascular disease or uncontrolled hypertension. gepants do not have that same contraindication. So going into triptans are selective 5-HT1B and D receptor agonists. Their action on the 1B receptor causes cranial vasoconstriction, and their action on the 1D receptor prevents the release of vasoactive neuropeptides. There are 7 different triptans on the market. I like to point this out because just because somebody doesn't respond to the first triptan you try does not mean that they're not going to respond to any triptans. So there is some value in kind of doing a little bit of trial and error to find the triptan that works best for them. Their sumatriptan is the only triptan that comes as a subcutaneous injection, so it has the fastest onset of action. It also comes as a nasal spray along with zolmitriptan. Zolmitriptan and rizatriptan also have an ODT dissolvable formulation. Naratriptan and frovatriptan are your two longer-acting triptans, frovatriptan being the longest with a 26-hour half-life. Naratriptan has about a 6-hour half-life. So these are really good options in patients that have long-duration migraine or patients that may get high 24-hour headache recurrence with their rescue therapy. If you talk to a headache specialist, they probably all have their favorite triptans. Mine is elatriptan. I like it because it's fast-acting. It has less of the kind of chest tightness, jaw tightness side effect that you can get with like sumatriptan or rizatriptan. It has less of the sedation that you can get with rizatriptan as well, so it can be pretty well tolerated. But like I said, there is utility in kind of cycling through to find the triptan that works best for patients. A lot of times people will come with sumatriptan and it causes side effects and they don't want to try anything else, but kind of that education that, hey, sumatriptan was the first triptan that came out. We have lots of other options that are better tolerated. It's worthwhile to try another one. Gepants, there are now 3 Gepants approved for rescue treatment for migraine. Ubrogepant and Rimegepant you may be familiar with. Zavegepant is the newest one. It's sold under the brand name Zavspread. It's the only Gepant that comes as a nasal spray formulation. Ubrogepant and Rimegepant are oral formulations. Gepants are small molecule CGRP receptor antagonists. So that means that molecule binds to the CGRP receptor and prevents the binding of CGRP. Because of this mechanism of action, they do not have vasoconstrictive effects. So they can be used in patients that have triptan contraindications, patients that have had a history of an MI, had a history of a stroke, have uncontrolled hypertension. And they're also well tolerated. So we talked a little bit about triptan side effects, which can really sometimes limit their use for patients. Gepants, on the other hand, nausea is the most commonly reported side effect that's seen in about 1 to 2% of patients. Additionally, they're not associated with medication overuse or rebound headache the way triptans can be, and they can be used in conjunction with triptans. So in the clinical trials for all of them, patients had the option to take, if they were prescribed a triptan for rescue, they had the option to take that triptan to treat the same attack if they needed to, so there's no interaction or contraindication there. The goal is to kind of give them something else in their toolbox to take as a rescue option. There are some interactions to be aware of. Ubrogepant and Rimegepant should be avoided in patients that are taking strong CYP3A4 inhibitors. So these are medicines like clarithromycin or erythromycin. They're not super common, but one thing to keep in mind. There's also a dose reduction to 50 milligrams in patients taking verapamil with Ubrogepant, and that's because verapamil will increase the levels of Ubrogepant. Excuse me. And then ditans is another newer class of acute migraine treatment. There's one on the market, lasmiditan. It has 3 dose options, 50, 100, or 200 milligrams. It has a pretty unique mechanism of action. So it's a selective 5-HT1F receptor agonist. It does not work on the 1B or D. So it does result in decrease of vasoactive neuropeptide release, but because it has no action on the 1B receptor, it does not cause arterial vasoconstriction. Kind of the downside with lasmiditan is that there are a few more side effects associated with it that can sometimes limit its use. So it has some reported nausea, sedation or dizziness, and paresthesias. Additionally, it has this 8-hour driving restriction. So after patients take a dose, they're not supposed to drive or operate heavy machinery for 8 hours after taking it. It's also a Schedule 5 controlled substance because there was some reported euphoria after patients took the medication. So there are, I think, a few more hurdles with using lasmiditan, but there is a population, I think there are some patients that can really benefit from this class in particular, and it's another option that we have that doesn't have that vasoconstrictive effect. So before we move on to the next case, any questions about acute migraine treatment? Look around a little bit. Yeah.
So in the, I guess in the emergency department,
Mm-hmm.
a migraine cocktail, what would you normally use for a migraine cocktail in the emergency department?
So the question is, what would you use in a migraine cocktail in the emergency department? And my preference in particular. So my preference is to try to keep people out of the emergency room as much as I can. But if you cannot, if patients are in the emergency room, The nice thing is that there are a few different options for treatment. Generally, we don't use dihydroergotamine or DHE in the emergency room. That usually require an inpatient admission or an outpatient infusion with specialized monitoring at a headache center. But in the emergency room, typically, a headache cocktail will include an antiemetic, so something like Zofran, Compazine, or metoclopramide, or plus Benadryl. Magnesium, IV magnesium can be helpful. Fluids, especially if somebody has been really nauseous, they've had poor PO intake. And then I like to add what I call a treatment medication, and that could be a steroid, so Decadron, Solumedrol, Toradol, so IV Toradol, anywhere from 15 to 30 to I've used 60 as well in patients. Depakote, IV Depakote can be a good option. And then IV Robaxin, actually, methocarbamol, which is an IV muscle relaxer, especially if people have a lot of significant like neck and muscle tension. I find that tends to be helpful too. One of the biggest downsides with infusion treatment, I think, in the emergency room is that they get one infusion and the patient feels better, but then the next day or the day after, their headache comes back. So it's not as long lasting. In our headache center, we have an outpatient infusion suite. So our typical practice is to actually have patients come in for 3 days of IV infusion. So we'll repeat that cocktail for 3 days, and the hope is to get kind of longer, really fully break that headache cycle and get longer lasting relief. Other options in the emergency room that you can employ are occipital nerve blocks, so greater occipital nerve blocks. If you're there in-house and you're able to perform those can be a really good option that can provide pretty quick pain relief for patients and kind of get you into, let you be able to discharge them into that outpatient setting for continued follow-up as well. Yes? So the question is, for this patient that has episodic migraine, if you start something like sumatriptan, when would you choose something different? Is that correct? For other patients. So again, you're kind of looking at the patient and what their needs are and how they've responded to triptans. So we also practice in the United States where we deal with insurance, and there's a lot of times for patients that do not have a triptan contraindication. So if they don't have, if they've had a heart attack or they've had a stroke, that makes it a little bit easier for you, right? They can't take a triptan, so then your option is to move on to a gepant. But for patients that don't really have those contraindications, many insurances now it's getting a bit better, but many insurances will require some step therapy where they need to have tried and failed at least one triptan. And by trial and failure, I think that the key there is to, a lot of times somebody will come in with headache, you diagnose them with migraine, you give them a triptan, and then there isn't that follow-up, right, to see how is that acute medicine working for you. And I think that's where we do a disservice to our patients when we're not following up with them to assess the need for optimizing their acute therapy. So I like to use, the question I like to use as a benchmark is, the goal with rescue treatment is for you to be pain-free and functional within 2 hours. Are you achieving that or are you not? If the rizatriptan that you're taking helps your pain, but you need to sleep for 2 hours and you can't watch your kids, or you can't, go to your meeting at work, or you need to still take a half day off of work, that's not helping you be more functional. That's not improving your disability. And that's the goal with rescue treatment ultimately. So if they're not achieving that, that's what I document. And I would consider that a triptan failure. And then we can try a different triptan. So like I said, just because they didn't, rizatriptan was a failure, doesn't mean they're not going to respond to zolmitriptan or almotriptan. So we can certainly try a different triptan, or we can move on to a different class like a gepant. I would say in general, I will usually try like 2 triptans and then move on to a gepant. With some of the newer formulary updates, a lot of insurances will actually only require like one triptan trial. So if somebody does want to try a gepant, I also don't shy away from using both a triptan and a gepant in the same patient, because patients will maybe have certain instances or certain headaches where they prefer to use their triptan, and then certain instances where they prefer to use their gepant. And these medicines have been studied together. There's no contraindication to that, and if we can help reduce that disability without them having to take a daily medication, that's okay to do, and that's still okay and should be pursued. Yes. Sure. So the question is there any role for IV chlorpromazine for acute headache? And there is a role for like acute headache treatment in the emergency department setting. I don't use it, on the outpatient setting or anything like that. But if somebody is coming in like a status migrainosis, you can use that in the emergency room. Usually you'll give it as part of like the cocktail. I thought I saw a hand over there, but maybe not. Okay. All right. So we're doing okay. We're doing okay. Yeah, I said okay. Now we're not doing great, but we're doing okay in terms of how far. Yeah.
So as part of acute management, I guess, is trying to prevent the problem.
Sure.
Can you just briefly talk about standard medication you recommend? You recommend magnesium for everybody? Do you recommend anything else?
So for preventive treatment. Yeah. So preventive treatment, we can talk about this now since you brought that up. So the question was, do I recommend anything kind of standard as preventive treatment? And it really depends. I think it depends on, one, what is the initial frequency of the headache that the patient has when they're presenting with you, and then what are the patient's goals? So my goal as a headache specialist is to prevent progression of disease. That's why early treatment is important. That's why I'm a big proponent of starting preventive treatment early. So I talk about preventive treatment with all of my patients when they're consistently averaging 4 migraine days a month or more. Even if they're averaging less than that, if they're in the 1, 2, 3 migraine days per month, we still discuss prevention. We'll talk about nutraceuticals, so supplements that can be kind of a benign but still effective preventive option to add in. So if you Google migraine and supplements, you're going to get a list of like 500 things, right, on the internet that people say work. But the ones that have been studied, and then I do have some supportive evidence behind them, include magnesium. So magnesium oxide or magnesium glycinate are typically the ones that I'll recommend, because those are better tolerated. They have better absorption and are better tolerated in terms of the GI effects of magnesium. Starting doses are usually 400 to 500 milligrams a day, and the dose can be increased up to 800 milligrams a day. For prevention. The biggest side effect is diarrhea or loose stool, so that's the biggest thing to watch for. If somebody kind of struggles with constipation, that could be a nice thing to add in. It has a bit of a smooth muscle relaxant property as well, so it can be helpful for like muscle cramps or something else if somebody's complaining of other symptoms there. Vitamin B2, which is riboflavin, also has some evidence. The dose for that is 400 milligrams a day. Pretty well tolerated. Vitamin B2, as you know, with energy drinks that are hyped up with B2, with B vitamins, it can be energizing, so that can be a beneficial side effect as well. Keeping in mind, I always like to ask patients if they're doing energy drinks, or if they're, I usually ask that when I'm talking about lifestyle, because I want to get an idea of caffeine intake and things like that. But you don't want somebody to get too much of certain B vitamins. And then coenzyme Q10 also has some good evidence. The dose is 300 milligrams a day. So those are usually, as part of my education with the patient, I'll talk about these supplements as an option to add in. For some patients, they are willing to do it. For some patients, not so much. The biggest thing with the supplements is that they require consistent use to be effective. So they can be really just as effective as some of our prescription medications, but they require consistent use and they can take longer to work. So 3 months of consistent use is considered an appropriate trial. So if people aren't able to keep up with them, it's kind of hard to really gauge if it's beneficial or not. But for somebody that wants kind of like a low-risk preventive option, that's a good place to start. Magnesium has some good evidence for menstrual migraine prevention. So for women that get pretty consistent menstrual migraine, either doing magnesium just within for like starting at like midway through their cycle, or just taking it every day can be helpful for menstrual migraine prevention as well. And then the other thing is, so we'll talk a little bit more, or we'll try to talk a little bit more about pharmacologic preventive treatment. But the other thing about migraine is, so we know migraine is a neurologic disorder. Migraine has a genetic basis, so there are genetic factors that lead to a migraine brain that makes you more predisposed to getting migraine attacks. But there are also all of these environmental and lifestyle factors, some of which are modifiable. And addressing these is so important with patients, and that's where that patient education comes in, because even if they're on great meds, if they're not sleeping well, if their mood is not well controlled, if they're not eating well, they're probably still going to get headache. And these are things that can be modified. And this is again something that comes with as you kind of build that relationship with that patient, build that rapport, and talk about what can we do to help decrease your headache frequency. Do we need to work on sleep? Do we need to screen for sleep apnea? You're drinking, a pot of coffee every day. Is that great? You're not drinking any water, so things like that. And that education can be really important. I think, many of us kind of have that little dot phrase that you put in the after visit summary, right? When somebody comes to see you with migraine, it's like, drink this much water and do aerobic exercise. But unless you're really discussing that with the patient, no one's really going to follow through on that, or no one's kind of reading through that except for like those select few motivated patients. So I like to kind of think, try to find that low-hanging fruit, and pick one thing. So if we talk about several lifestyle factors, like what is one thing that we can work on until our next visit. So I always find drinking water is like a great one to start with, because many people are not drinking enough water, and that's an easy way. You can give them some strategies, give them a goal of 100 ounces a day or whatever, and then give them something to work on until your next visit. And I think as opposed to being like, you need to do these 6 things, that's a lot harder, and people won't be able to maintain those lifestyle changes. Whereas if you do one thing at a time in a stepwise approach, I think it's more sustainable for long-term management. And that's so important for prevention, and preventing progression of the disease if we're kind of monitoring those lifestyle factors for things that are modifiable. Yes.
After you have addressed all of those modifiable factors and the patient continues to have multiple migraines, you've done, I'm thinking about a patient who has migraines before, maybe prolonged before, and thinking about the relationship between migraines and PFOs. Do you think that there's ever really any utility in going ahead and maybe getting an echo to see if they have a large PFO?
So the question is, thinking about a patient that has migraine with aura, and you've tried multiple preventive treatments and lifestyle factors, and then you're wondering, and their headaches are persisting, and then is there any utility of getting an echo to look for a PFO? And this is a bit controversial. So PFO is associated with migraine with aura, but at this point there is not enough evidence to say that PFO closure is helpful for migraine with aura. So if it's present, it's present, but I'm not like referring them to cardiology to close the PFO. We're still exploring more preventive options at that point. Yes. I'm sorry, can you repeat? Alcohol? So the question was, what percentage of patients with migraine get exacerbation with alcohol? I don't know the percentage off the top of my head. And I think it would probably, it's pretty individualized in that alcohol is not always a trigger. Similarly with like other diet triggers, right? I think migraine diet is like really hyped up a lot, online and with patients, but really only 30% of migraineurs have reliable food triggers. So yes, there's a migraine diet that you can follow, but I'm not a proponent of like saying you need to cut out all of this stuff if you're not sensitive to it. One thing if you can reliably say that, this food triggers your migraine, but if it's not consistent, you don't really need to cut all of that out of your life. So similarly with alcohol, wine tends to be a bit more of a trigger for folks because of the what's it called? Yeah, the tannins. I was like, it starts with a T. So wine tends to be a bit more of a trigger as opposed to like lighter alcohols, but I'll ask patients, can you reliably identify that as a trigger? If you can, then why don't you try to cut it out? Some people don't want to, and it's like, well, then you probably will still get a headache, and then we can try to optimize your rescue treatment. But, if that's still going to be a trigger that you're exposed to, then you may still get a headache there. I don't have a specific percentage, though. I don't know a specific percentage for how many people are triggered by alcohol. Okay, another question? So we have 5 minutes. What should we do?
If your third case has specific teaching points, then you can probably just go.
Okay. Okay, so the question was, do I have patients that don't respond to anything? And then what do you do? And the answer is yes, I do. And I think at that point, you kind of have to look at, so first of all, making sure that your diagnosis is correct. Does this patient really have chronic migraine? Do they have other factors? So is there cervicogenic headache? Is there musculoskeletal or myofascial pain? Do they need physical therapy? Do you need to kind of explore that avenue a little bit more, looking at muscle relaxers or medications to kind of target that myofascial pain? Do they have untreated mood disorders, or do they have untreated sleep apnea? Are those risk factors that we can modify? Do they have a chronic pain syndrome? So do they have central sensitization? Are they describing things like allodynia, where our typical preventive treatments are not going to be as effective? Keeping in mind that our goal, migraine is a chronic disorder. There's no cure for migraine. Similarly, there's no cure for chronic pain syndrome. So our goal is not zero pain. And I always like to set that expectation with patients in the beginning, especially somebody that has chronic migraine that I'm seeing. Our goal is not zero pain. Our goal is improvement of functioning, right? Reducing your disability and improving your functioning. And this is something that happens over time and is typically a multidisciplinary approach. So in these patients, we are lucky at Cleveland Clinic that we have a pretty robust pain management and chronic pain recovery center. We have several multidisciplinary programs that utilize pain psychology and physical and occupational therapy. We have our pain recovery program does ketamine infusions for refractory chronic pain. So we have some options there. For refractory migraine, I also like to look into neuromodulation devices. So there are a few available on the market, the Suffly device, the Nervio device. There's a newer device called Relivion. There's a device called GammaCore. So there are some neuromodulation devices that can provide some benefit for patients, especially patients that aren't able to tolerate some of our pharmacologic therapies. So that is those are some avenues to explore. And then I do think, in patients that aren't responding to treatment after you've kind of touched, making sure you're not missing anything else. Really, oftentimes these patients need support, and that's where pain psychology really plays a role in kind of changing the perspective and how to be functional despite the pain, or what are those small stepwise increments that you can do. I don't always find throwing more and more medications at a patient is effective. And at that point, also kind of having that conversation like, hey, you know, we've tried these classes of medicines. You haven't responded to these. I don't know if there's another class of medicine for us to try, but what are your goals, or what are some small things? What can we help you improve? So kind of doing that stepwise approach. Yeah, we have 1 minute, so. Yes. So, are you testing me? So the question was, can you describe the neuroanatomical pathway of the greater occipital nerves to the trigeminal complex? So the origin of the greater occipital nerve is your cervical spine, right? It's your C2 and your C3 vertebrae. So the greater occipital nerve, as well as the lesser occipital, and then the third occipital. So you have 3 occipital nerves on each side. The third occipital nerve all originate from the C2 and C3 vertebrae. They travel within the muscles. They kind of interweave within the muscles of the neck. There's a really good picture on Netters that kind of showed that I like to show patients as well, because there's so many little intricate branches and all these intricate neck muscles that the nerve is weaving through. So you can imagine if there's muscle tightness or spasm, neck muscle tightness, if they have cervicalgia, there can be a lot of local irritation of that nerve that contributes to occipital neuralgia. And then it travels up the back of the head. So the greater occipital nerve, the third is the most medial, then the greater occipital, and then the lesser occipital that comes kind of behind the mastoid. There are small branches of those nerves will travel in toward, and then they don't travel directly to the trigeminal cervical complex, but they, I think they just branch out, but they don't travel into the trigeminal cervical complex. The trigeminal cervical complex, yeah.
Anybody else? 1 minute. So the other groups haven't come running in yet.
Yeah, well, about Botox. Yeah, so Botox, onabotulinum toxin is a preventive option for chronic migraine. Because of insurance restrictions, it's typically used in a population of patients that are refractory, so patients that have tried and failed at least 3 preventive classes of medication and then have chronic migraine. I think I have a picture of it. So we used the preempt protocol. That was a protocol that was studied. It uses 155 units of Botox. That was, sorry, this is like, it's going to be like way down here. So it's 155 units of Botox that is administered in 31 injection sites every 3 months. It has a kind of a dual mechanism of action, so it inhibits nociceptive neuropeptide release from the afferent neuron, so it attenuates peripheral pain signaling to the brain, and it also has a central action as well by releasing the inhibiting the neuropeptide release. Yes, the question was, what about topiramate? So topiramate is a preventive option for migraine, and it's still something that we use. I think everyone else is coming in. So we'll just take a break.